All right, welcome back to the Dr. Doug Show. Today, I have an awesome interview that I want to share with you. Today, I interview Dr. Amie Hornaman. And Dr. Amie Hornaman is a friend of mine. I've been on her show, and I love her work. So she is all about the thyroid. So if you are concerned about your thyroid, you think you have symptoms of low thyroid, you feel like you're being blown off by your doctor about your thyroid, this is going to be a great episode for you to listen to. Let me just give you a little bit of her bio here. So Dr. Amie Hornaman is known as the Thyroid Fixer. She is the host of her own podcast, which I've been on, called the Thyroid Fixer, and she has a really big following. She has her own supplement line. She is just such a big advocate for anybody who is struggling with thyroid. She has her own incredible journey, which she'll share a little bit of today. She has her own practice and is available for consultations. And so we'll put all of her contact in the description after the episode. So without further ado, all right, so let's get to it. Here's Dr. Amie Hornaman. All right, Dr. Amie, the Thyroid Fixer. So good to have you on my show. I really enjoyed our conversation last time we interviewed each other, it kind of felt like. So happy to have you here and really get into some of the details of thyroid. And I want to weave in some things around bone health. I want to weave in some things around sex hormones. So I'm really excited for this conversation. Thank you so much for your time.
Oh my goodness, I'm excited to be here. It's an important message. We have to get it out.
Yeah, that's great. So let me just lay the groundwork for this, which is most of my audience already knows when we talk about bone health, we're talking about bone health really through the lens of Healthspan. And therefore, we talk about heart disease, we talk about dementia, we talk about sex hormones. We also talk about the thyroid, although I don't do a lot of videos on the thyroid because it's just something that we make sure that we're addressing. But the research on thyroid and bone health is just not that clear. But before we get to that, let's start with some of the basics because I think there's a lot of confusion around thyroid and what is low thyroid and what is hypothyroid and what are these symptoms that people should be looking for and not hopefully getting dismissed from. But what are the things that we talk about when we talk about, what is low thyroid? What is hypothyroid?
Yeah. So let's start there. Low thyroid function, hypothyroid, low and slow thyroid function, it can exist on its own as directly, your thyroid gland just is in the toilet, it's not working well. Maybe you had radiation, chemotherapy, certain medications, even birth control medications can lower thyroid function and affect the thyroid gland directly. But 95% of all hypo, low, and slow thyroid function is Hashimoto's or the autoimmune form. So it's where your body, I always love to give analogies. It's like your body has a group of soldiers, and those soldiers are totally confused. They're not working for you. They're working against you. They think that your thyroid gland is a bad guy or an invader, and they launch a war on your thyroid gland. So that's where we see autoimmunity, and we could use that analogy across the board. We could use it for rheumatoid arthritis, where your soldiers attack your joints. We can use it for Crohn's disease, where your immune system or your soldiers attack your gut. So in the case of Hashimoto's, your soldiers are attacking your thyroid gland. And when you get attacked, so like if I came over your house and beat you up every day, Doug, you're probably not going to work really well. Like you wouldn't want to do interviews. You probably would just want to lay on the couch, Same thing with the thyroid gland. When it's getting beaten up every day, it just doesn't produce the proper amount of thyroid hormones to fuel our body. So now we can get into the symptoms. Okay, well, what do we notice when our thyroid gland's being attacked? Or what do we notice when our thyroid gland isn't working up to par? This is where we'll see weight gain, the inability to lose weight no matter what you do. You could be doing the most perfect diet, going to the gym a couple times a day, doing your yoga, meditation, all the things, counting your macros, and the weight is not coming off. Extreme fatigue, heavy eyes, constipation, hair loss, dry skin, cold intolerance, heat intolerance, and we can even go a little bit further into the less common symptoms of hypothyroidism: joint pain, frozen shoulder, symptoms of rheumatoid arthritis. I've had many patients where their hands didn't even work. They couldn't hold a pencil. And once we got them optimized, it's like, oh, wait, I didn't even realize that this was correlated to the thyroid, but it was. Brain fog, depression, anxiety. I've had patients come and say, I think I have early Alzheimer's. I'm like, no, you just don't have enough thyroid hormone to fuel your brain, because there are receptor sites on the brain for thyroid hormone. So the symptoms are long and vast, but if you really think of the thyroid gland as the master gland controlling your body, it kind of makes more sense where each individual symptom can tie back to the thyroid gland not being optimized, because the thyroid has that direct effect on all systems of the body. So even blood pressure, heart rate, the ability to take deep breaths when you're exercising, all of that comes from the thyroid.
Yeah. And I mean, you already said it. It's called the master gland, right? And it is connected to everything. And we're going to talk about some of those connections. But one of the challenges I have with thyroid is, when we talk to patients about symptoms of low functioning thyroid, we're looking at their biomarkers, but the symptoms so often overlap with other potential causes of similar symptoms, right?
Yeah.
So can you help me? How do you help differentiate this when you're working with a patient? Differentiating, the fatigue from low thyroid versus the fatigue from, say, low sex hormones, or the fatigue from just like bad sleep hygiene. How do you help to get through this maze of these relatively vague overlapping symptoms?
Yeah. Well, first you test, don't guess. So we just test everything. So even when I first meet with a patient, we first meet with a patient, we'll run the whole gamut just so we can sit down and have that full picture in front of us. And then you start to unpack, or you peel the onion and you're talking to the patient and you realize, okay, wait, no, they have their lifestyle, their nutrition, all of that is down pat over here. And what we're seeing on their labs is low free T3, which is your active thyroid hormone. If that's low, then that's going to tie back to that low function of metabolism, brain, energy. So that kind of starts to make sense. Then we look at, and I know we'll get deeper into the labs, but we'll look at
Yeah.
different lab markers for the thyroid. Reverse T3 is another one that, if elevated, it locks the body down and puts your body in survival mode. So we know that that could be playing a factor. But then we move over here and we do look at all of the sex hormones, and we look at various markers. Ferritin is another one that can tank your energy. We'll look at vitamin D levels. So it's about looking at that whole picture and then looking at the patient and asking them the four most important questions that you could be asked by any, or four most important words that you could be asked by any provider. How do you feel? Because how you feel gives us that pairing, that beautiful picture where we can finish the puzzle and we can say, okay, Mary, your weight gain could be coming from the fact that you're moving into perimenopause or menopause. Your estradiol is low, your testosterone is low, but over here your thyroid is not functioning well. Oh, look, you have Hashimoto's too. And because the thyroid gland is off, and I know you're eating keto and carnivore, but you're also insulin resistant. So all of those things are playing into your symptoms. We're not just going to address one, we're going to address them all.
Yeah.
That way everything starts to work together like a symphony to ultimately alleviate the person of their symptoms, because that's what they want. They really don't care what's on their labs. They're like, can I just, sleep and have my brain function and lose some weight? Like that's awesome, right? So we get them feeling better, but then we start to see those changes in the labs just to, incentivize the patient, like keep going, keep doing what you're doing, because we're seeing these changes.
Yeah. Well, let's get into the lab. So I think we get so many questions, not so much from our patients because we're getting a very extensive lab panel, but oftentimes in our Osteo Collective community and our YouTube comments, I mean, people just there's so much confusion around the labs because, let's face it, most doctors in the conventional system are not getting a complete lab panel. So let's just I'm just going to I'll walk through the ones that we get, and then if you get more, then let me know. So let's start with the TSH, the thyroid stimulating hormone. It is if you're going to check your thyroid and you go to your primary care doctor in the conventional system, they're going to get a TSH, and maybe that's it. But walk us through what TSH means for you.
Right. So it's a brain hormone. That's what we have to remember. It is a brain hormone. It's not a thyroid hormone. Now, another analogy for you, this might be a really bad one, but this is kind of how I picture TSH. Like a blind man with a stick, feeling the surrounding areas, feeling what's around. So the pituitary is like feeling it out. Hey, is there enough thyroid hormone in the body? Yes? Okay, well then we can be quiet. So the pituitary will quiet down, and it won't have to yell at the thyroid gland to do its job. But if the pituitary feels like there's just not enough thyroid hormone in the body, it starts to yell. It's like when your kid doesn't listen to you. You know, Johnny, can you pick up your toys? Second time. All right, Johnny, you got to pick up your toys now. You know, your voice gets louder. Well, same thing. The pituitary starts to scream at the thyroid, hey, thyroid, you're not doing your job here. You're not making enough thyroid hormone. You need to wake up. And this is where we see TSH go up. Now, when TSH goes up, and in functional medicine, I'm sure you have very similar optimal ranges, but we like to see TSH below a 2. And even if it's below a 2, we can still see non-optimal thyroid function. So we don't stop there. But when the TSH is screaming, when it's above a 2, then we can go, oh my gosh, you know, Mary, there's blatant hypothyroidism here. Let's keep going. We're not going to stop at the TSH and just diagnose you from that, but let's look at the full picture. But from that TSH being high, it tells us that your pituitary is really screaming at your thyroid to make more, and your thyroid is not listening. But we have to move on beyond the TSH.
Yeah. All right. So then let's move on beyond the TSH. And I'm actually going to come back to it when we talk about treatment. But let's move on beyond TSH and let's talk about, so what I look at next when I'm actually doing this with a patient, the next thing I look at is free T3, free T4. So you want to walk us through what these mean to you and kind of how you use these tools?
Yeah. So 2 thyroid hormones. Now we're into the thyroid hormones. So T4 is the inactive thyroid hormone and T3 is the active thyroid hormone. So the thing to remember is that on every cell in your body, there is a receptor site for T3. There's not a receptor site for T4. So T4 has to become or convert over into T3 in order for it to have that effect on the cell. Just like a lock and key mechanism, the key goes in, turns. Now, oh, my metabolism is turned on. Now my brain is turned on. Now my energy is turned on. So without enough T3 active thyroid hormone, you can't turn on the body. You can't have it working at an optimal level because it needs to be in that T3 format to attach to the cell to do its job.
Yeah. Yeah, that's a really great description of it. So then here's the question that we get a lot, which is people will say, "Oh, well, my doctor measured my T3 and T4," but they're talking about total,
Right.
not about free.
Right.
So I measure those too, but I'm not as interested in the total. What's your take on total versus free with those hormones?
Same as you. You know, we can look at the total, and then I'm sure too that you'll have some patients or individuals in your community, because we see this as well, where they'll post their total and their doctor didn't test their free.
Yeah.
But when you see a low total T3, well, there's not going to be enough free then. So at least you can glance at that and go, well, you know, you don't even have enough total, but we still do want to see how much free. So free means unbound, ready to attach to the receptor site on the cell. That's why both of us prefer to look at the free forms of those thyroid hormones rather than the total.
And what's your take on the argument that I get from, particularly primary care doctors who say, look, the free T3, it moves up and down so much. Why would we even measure it? We don't really know what we're measuring.
You still have to look at it. So how I have my patients test is, number one, 18 to 24 hours with no thyroid medication containing T3 before a lab. That way we don't get a false high. We don't pick up on the medication that you just took. And then I say, now every time you test, whatever interval you chose, let's say you chose 18 hours. So you took your last dose of thyroid medication the day before at 2 p.m. And then you did not wake up and take your thyroid medication the next day. Instead, you got in the car and you went to the lab and you got your blood work. So let's say it ends up being 18 and a half hours. Well, then the next time you go, I want you to do that same interval so that we can see an apples to apples comparison. Whereas if you even divert slightly, let's say the first time you go 18 hours and the second time you go 24 hours, yes, we will see that free T3 level drop. And then I'll have patients say, well, wait a minute, my free T3 dropped. And I go, no, it actually didn't. You went longer and it was just working its way out of your system. So by the time you got to the lab 24 hours later, it was out of your system. Now I always try to tell patients, go first thing in the morning. Don't do these 2 p.m. lab reads, because even TSH can change throughout the day. Right. But as long as we're doing that apples to apples comparison every time you do your labs, and then we pair that up with how do you feel, and we pair that up with your symptoms, we can get a pretty accurate read on where you're at in your thyroid treatment.
Yeah. Yeah, this is a tough one for us. So we were there, and then we switched to recently now, because I know my patients are going to listen to this and they're going to say, but that's not what you told me, Dr. Doug.
Right, right,
Um,
right.
so but let me just explain why. So we were, when you do that, you're going to get a trough of their treatment, which again is fine as long as you're measuring trough to trough and you know what
Yeah.
you're measuring. And so we had some patients that started, one of our providers was making the recommendation to take it morning of, but then test 3 to 4 hours later. So you are getting a peak,
The peak. Yep.
which I don't think is wrong either. You just have to know that it's a peak and not
That's it.
and not the middle or not the trough. And so that's why we've kind of gone that route. I don't know which is better at this point because they just tell you different things, but you can't do both. I wouldn't have my patients repeat labs every 4 hours.
Right.
So it's interesting that you've gone that route and you find that to be helpful. I'm curious your thoughts on then if you are getting a trough, if they're still having symptoms, is the dose change then just based mostly off of symptoms and then obviously knowing what their trough is?
Yeah, I'm going to back up to what you said and then kind of move forward.
Sure.
So I want to validate the fact that you are testing at the peak. I'm fine with that if someone is working with an individual like you that knows what they're looking at.
Mm-hmm.
The problem is that many of these, and I know you see this too, so many of these people are working with other practitioners, even
Right.
other functional and integrated practitioners. If they don't know the thyroid, and oh my gosh, especially if you're doing this with a conventional practitioner, you're going to get told that you're hyper.
Yeah, that's right.
So let's say you do that 4-hour test with anybody else other than Dr. Doug and his team. And then that individual goes, oh my gosh, Mary, your free T3 is a 6.5. You're getting flagged high. We need to drop your T3 dose. And Mary's there going, wait a minute. No, I just started to feel normal. I just finally
Best
lost
I've
2
felt my whole
pounds,
life.
right?
Yeah.
And they will pull that medication out of your hands and you're going to go hypo again. That's why I tell people the 18 to 24 hour,
Yeah.
just simply because so many people out there are listening. And oh my gosh, if they do that with a conventional doctor, they're going to go
Yeah.
deeper
Totally.
hypo than they already are.
Yeah.
So I'm totally fine with that. The other piece is when we're testing. So I base my optimal lab value range on that trough. So when we're testing there, this is where I say, okay, we want that free T3 in the upper quadrant of the lab value range. So if you're using something like LabCorp, you really want it maybe like a 3.9 to that 4.4 range, whereas you're going to be way over that if you're testing at the peak. So that's also why I do the 18 to 24, because when I give those optimal ranges, it's based on the trough. But if you have other optimal ranges for the peak, then
Yeah.
that's totally separate.
And
Right.
again, right, it's that consistency, right? So we know what we're looking at, and,
Yep.
and we always ask them, "Hey, when did you take your medication?" And right, so
Yep,
yeah, so
exactly.
it's just interesting. There's different ways to do it, and definitely neither are wrong. You just have to know what you're looking at.
Right.
So then let's move on then down the panel. So the next thing I look at often is reverse T3, and you kind of already mentioned it, but walk us through again, like how crazy is it that the thyroid, or I guess that the cells actually do this, right? So how crazy is it that that the cells in the body have this pathway? So just describe it for us, and what does our T3 tell us?
So reverse T3, we want it. We want it in our body. It was beautifully built into our system to protect us in times of trauma or injury. So let's just say, you were in a car accident, you get taken to the ER, you're in the ICU, they pull a reverse T3. Well, hopefully it's elevated,
Right.
because that tells us that your body knows that in this moment in time, you don't have to burn fat. You don't have to grow your hair. You don't have to think. You don't even have to poop every day. You have to lay there and survive. And all systems must go shift away from metabolism, shift away from digestion, shift away from the brain function, and go to healing this person, healing that injury,
Yeah.
and keeping them alive. The problem is that if you ask for a reverse T3 in conventional medicine, you'll get told we only test that in clinical situations, such as you being in the ICU or the ER. Okay, that's great, but what if my reverse T3 is keeping me in survival mode when I'm not lying in a
Right.
bed dying somewhere? I'm
Yep.
trying to get through my day and run a business and run a family and cook dinner and take the kids to soccer. Like, that's the last thing you want is your body to be in survival mode. That's why we test that reverse T3. Now, The only thing that converts to reverse T3 is T4. It's the inactive thyroid hormone. So we talked about how T4 has to convert to T3 earlier. I want you to think about it having two paths to go down, and it has to decide on which path it's going to go. Now, hopefully we can push T3 down the path to become, or T4 down the path to become T3. That's the perfect world. And many people do convert just fine. And we look at their reverse T3 and we make sure, I like it below a 12. We make sure that it's in that optimal range. And we say, okay, you're handling your T4 thyroid hormone, or you're converting your own thyroid hormone properly into T3. Now, it can go down the path of reverse T3. Things that make it go down that path are many. I always say the T4 to T3 conversion is actually like running 5 Tough Mudders in the same day. Like, it's really hard for your body to do because of the world that we're in. So if we think about and these are just some of the factors that influence conversion: low iodine function, insulin resistance, estrogen dominance, low magnesium, low selenium, low vitamin D, low ferritin, not enough protein, a D101 or D102 genetic SNP that can actually make you a non-converter. And then we have conventional medicine loading people down with T4 medication.
T4, yeah.
You know, again, Mary comes into her conventional doc. Well, doc, I'm not feeling, oh, well, let's take your T4, your Synthroid, from 112, let's take it to 125. Oh, you're still not feeling good? Let's take it to 150. Let's take it to 175. And they're just loading this person down with more and more T4. And Mary keeps saying, I'm getting worse.
Yeah.
Why am I even taking this thyroid medication? It's pointless. It's not helping my symptoms, and I'm actually feeling worse. Right, because you're taking so much T4. No one looked at your reverse T3. No one looked at your conversion pathway. You're converting most, or if not all, of that T4 to reverse T3, and you're making yourself go into that survival mode. And so it also becomes a problem of conventional treatment and standard of care of the thyroid that raises reverse T3.
Yeah, we've definitely seen that too. And we're going to talk about treatment here in a minute. But yeah, we see that very, very frequently where our T3 is high. And people say, well, is it stress? Is it, this or that? And there's lots of answers, right? But we look at it as part of the big picture where we say, look, you don't have enough free T3, enough thyroid hormone at the cellular level to do what it needs to do, even though you're on a ton of Synthroid, even though you're on a ton of T4 therapy. We see that very, very frequently. And then here's the connection to bone health, which is the doc keeps driving up the T4, and then their TSH might start dropping, and then they're going to say, "Oh, well, now we're going to cause osteoporosis because your TSH is under 1."
Right.
And we'll get to that too. But this is the trap that we see, because then women in general are going to come in. They're not going to have adequate T3. Their doctor told them they're on too much medication. They have fear around osteoporosis, and they're like,
Yeah.
That's such a big mess. But before we get to those two really fun topics, let's talk about the antibodies. So you mentioned Hashimoto's. You mentioned it's like this happening. You see it so frequently. I see it so frequently. Can you just define sort of biomarker-wise, but also like what does it even mean? Because I think this term gets thrown around a lot. So what is Hashimoto's to you?
So according to labs, I will call Hashimoto's when any antibody is present. So yeah, we could take a standard lab value range for thyroid peroxidase. So there are two markers. There's thyroid peroxidase and thyroglobulin. Let's take thyroid peroxidase, most common marker when we're looking for Hashimoto's. And we see on LabCorp, the standard lab value range is less than 34. I can't even remember whether LabCorp is less than 9 or less than 34, but we'll take less than 34. And someone rolls in with a TPO of a 15. Well, my doctor told me I did not have Hashimoto's. I go, okay, well, you have 15 soldiers right now that are beating up your thyroid. You're telling me that you've gained 10 pounds, that you need a nap every day at 2 p.m., and that you're counting the hairs that are falling out of your head in the shower. So are we going to wait until that TPO crests 34? Wait till you get 35 and you get that little H next to it, and then it's red on your labs. And then we can say, okay, now you have Hashimoto's. Now we can treat you. Meanwhile, now you're 20 pounds heavier. You lost your job because you can't even go to work, right? And you're damn near bald. So why don't we treat it when we first see it and actually address that person, ask them, how do you feel? And look at those antibodies and say, listen, your immune system is confused right now. And there are things that we can do immediately to boost your natural immune system, which I know sounds counterintuitive when we're talking about autoimmunity. We do want to support our natural immune system while at the same time reducing those antibodies. And there's some very simple things that we can do.
Yeah.
We can go a completely gluten-free, not 98% gluten-free, 100% gluten-free. We can take things like black cumin seed oil, which I've seen lower antibodies 200 or more points and literally push someone into remission. Controlling stress, controlling cortisol. Oh, elevated cortisol is another driver of reverse T3. So it's great to just control our cortisol levels and control our stress across the board when we're talking about thyroid. But there are so many things that we can do to put someone into remission and literally lower those antibodies to zero, but we don't ignore it when we see antibodies present and wait for someone to get worse and wait for someone to get the little H, that little marker on your labs where then, you're actually diagnosed. Maybe.
Well, and the challenge I see with that too, because we're very similar, where we have very low thresholds for saying, look, you have Hashimoto's thyroiditis. We need to more aggressively take a look at what's causing this autoimmunity. But the challenge is even if their conventional doctor is saying, well, we can't call this Hashimoto's yet, but what are they going to do when they do? Because they don't have a tool for it anyway.
Right.
So yeah, so we just sort of have to realign. We have to take the vision and say, okay, look, we're just going to treat your thyroid. I don't actually care what you call it. We know that you have symptomatic low thyroid function, so let's just treat it. Right. Our approach has been very much to try to look at the gut for sort of the underlying cause of autoimmunity. Do you guys go down that pathway?
That's right. Gut, liver, both of those, again, tied to reverse T3 and tied to autoimmunity, 100%.
Yeah.
Yep.
It's a big thing for us because so many of our patients, all of our patients have osteoporosis for the most part. So the gut dysfunction just comes hand in hand. I don't know, chicken or the egg, but
right.
We just see it. We see it everywhere. So we're going down this pathway anyway. And so we do always see, like gut lining dysfunction, permeability increases, et cetera. So there's definitely a tie there because we see the antibodies go away. After we treat it. Yeah. So
it's a whole three-legged stool analogy, right? So I always attribute that to Alessio Fasano, kind of like the father of gluten and gluten-free, and he's hilarious to listen to. But he describes that three-legged stool where you have that genetic predisposition for autoimmunity, you have the leaky gut, and then you have the trigger. So that's why we were talking off air about, I have the term thyropause that I talk about a lot, and it's when your thyroid gland basically craps the bed after the age of 40 from fluctuating hormones. What that means is those fluctuating hormones were the trigger. They were the third leg of the stool. But the whole analogy around that three-legged stool is if you kick out one of the legs, the stool falls. So going back to what you just said, when you heal that leaky gut, autoimmunity essentially no longer exists, even if you have the genetic predisposition and even if you have a trigger such as hormonal fluctuation. You have to knock out one of those legs.
Yeah, so it's been a powerful tool for us, but it takes time and it takes a lot of work. So if you're out there struggling with this, know that this is not always a quick fix, unless you're working with Dr. Amie, the Thyroid Fixer.
It's still not a quick fix, but you start to. It's a marathon, not a sprint. But my gosh, isn't it nice to get your life back in like 4 months? As opposed to 2 years as you're
and let's just get started, right? And this is the big thing for a lot of people is like, let's just get on the road. There's something that feels really good about having a destination, even if it's pretty far away, just at least knowing like, hey, this is where I'm going. I think that's really helpful. So then I'd love to talk about your thoughts on different types of treatment. So you kind of mentioned like people taking T3, you mentioned Synthroid. Can you walk me down your just general pathway for someone who has, just you can describe whatever lab values you want, but like, how do you treat people? Because we're probably very similar that taking T4 is not the answer for the vast majority, I think, of people that I see.
Right.
That I do see some people that look like they do great on T4 only therapy. So I'm not going to say it's never a good option, but generally for the patients that I see, their labs don't look good and they don't feel good. So how do you treat patients?
When patients come to see us, they're pretty far down that path. Now, I literally just recorded a podcast going through things that you can do to naturally reverse your hypothyroidism, Hashimoto's. But I always put that caveat in there that it just depends on how far down that path you are. So there are some people listening that maybe they're just in those beginning stages where we're just seeing the numbers change. And maybe they only have a couple different symptoms and they're not horrible. They would be your people that they're like, I don't have a ton of symptoms. I'm okay. Maybe I have, like a 5-pound weight gain. Maybe I'm a little bit tired. And we see their numbers get a little bit wonky on the labs. At that point in time, we can come in with some natural interventions that really do work. L-tyrosine actually helps stimulate the thyroid gland to produce more T4 and T3. Iodine, magnesium, selenium, vitamin D, all of those will help convert T4 to T3. So we can support the body in a variety of different ways. Black cumin seed, like I mentioned earlier, can lower the antibodies. So if you have 50 antibodies, we can take them to 0. But most of the time, when I see patients come in, they're pretty far down that pathway. Maybe they've had Hashimoto's for 10 and 20 years and no one has told them. Or maybe they've been on T4 with 0 change in their symptoms for 5 to 10 years. And at that point, it's like, we're not going to do this naturally. We need to replace thyroid hormone that is no longer being properly made by your body. So I always encourage people to think of thyroid hormone replacement outside of the medicine category. We have a lot of people that say, I don't want to be on medicine or on a medication.
Yeah.
And I said, well, okay, you don't want to be on the Band-Aid medications that you're going to get from your PCP. You don't want to be on the antidepressants and the sleeping pills and the statins and the PPIs for your gut and your heartburn. You want to be on a hormone, which is thyroid or testosterone or progesterone or estrogen. Those are all in the hormone replacement category. So we're replacing those hormones because we have the power to do so now. We're replacing those hormones that are just no longer being properly made by your body. Your thyroid gland's been at war for 20 years. It's tired. Right. It's not going to produce enough T4 and T3. Forget about it. So that's where that nuanced thyroid hormone replacement treatment comes in. And this is where you really have to get down and dirty with a person. You really have to look at each person as an individual, a unique bio-individual, like bio-individuality when it comes to treatment. Because you have to look at, okay, their reverse T3, their history, have they had an elevated reverse T3 for a while being on T4 only? And that way you can really tailor that treatment. So I use a variety. I use any combination possible. And I want to give just a quick story. Years ago, I was speaking to a group of integrative doctors, and they wanted me to give a presentation on the thyroid. So we talked about why aren't we testing reverse T3? Because these docs came from the conventional system and then were kind of stepping into integrative medicine. So I said, why are we not testing reverse T3? And then I said, why are we in the Synthroid box, meaning the T4 only box? I said, if someone comes into your office with depression, you'll give them this antidepressant. If that doesn't work, you'll try this one. If that one doesn't work, you'll tag on another one, and then you'll throw in a benzo for their anxiety. But if someone comes in with a thyroid problem, you give them one medication only, and that is T4. Why is that? Mm-hmm. And the one doctor raises his hand and goes, that's all we've learned. So I'm like, okay, well, thank you for being honest. That's awesome. But now it's time to unlearn what you've only learned and bring in all the other treatment modalities. So we have NDT, which is natural desiccated thyroid. We have Armour and NP. There used to be Nature-Throid. Some of you may have taken that. That was taken off the market, I know. But now we have NDT, we have NP thyroid, we have Armour, and we have compounded T4 and T3 from a compounding pharmacy. Then over here we have your T4s, which are Levo, generic, Synthroid is brand, Tirosint is another brand, even more pure, and Tirosint Sol is even more pure than that in liquid form. And what I mean by pure is some people react to the fillers in different medications. Mm-hmm. So if you put someone on Levo, generic, it has corn, it has gluten, little specks of, but some people are very reactive to that. So we can kind of go up in the T4 category, let's say, kind of like from, what is it? What were those little cars, like Yugos to a Cadillac, right? And then we go over here and we have T3, and we have liothyronine, and we have cytomel. Now we can combine any of those. We can use a little baby dose of T4 and more T3. We can use NDT and T3 because NDT is 80% T4 and 20% T3. That ratio doesn't always work for everyone. Right. So maybe we change that ratio by adding in some T3. Now we're giving you, let's say, 60% T4 and 40% T3. we can personalize your treatment to the max to find out exactly what is going to work for you. So that's, I mean, really, when I get the question, what's your favorite thyroid medication? I go, the one that's going to work for you and the dose and combination that's going to work for you.
Yeah.
That's my favorite.
Yeah. No, that's great. And I love the way you laid all of that out there. And it's for some reason, it is scary as a physician to get into using T3. I remember when I first started getting into the integrative space, I was like, ooh, like they're going to go into a thyroid storm, and
Yeah.
this is really dangerous stuff. Of course, I also thought the same thing when I started doing hormones. So what can you tell people about, especially like physicians that are listening who are like maybe I'm not doing enough. What has your experience been using T3? Like, are we playing with fire here, or can this be done responsibly if you understand how to use it?
It can absolutely be done responsibly. It can save someone's life. So if I didn't have an open-minded doctor, I wouldn't be sitting here with you today, because I am on 150 micrograms of T3 only, which would make most conventional physicians fall over and like just have a heart attack on the spot. They
That's a
can't
lot.
even fathom it. I have one patient that's on 200. I have patients that are optimized on 10. So that is that individuality of treatment. And you can see, okay, some people, you could have them on 10 micrograms and take them to 15, and they're like, oh my gosh, I'm anxious, I'm crawling out of my skin, I just don't feel well, I can't sleep, I'm sweaty. So they've moved into a hyper state. It's too much for them. They're over medicated. You got to bring them back. So always listening to the patient and teaching the patient how to listen to their own body as well, and report symptoms like that and not ignore it. And that, because you're going to know when you move into that hyper state, you absolutely know. And so that is a sign to back off, and you back down to that last dose that you were on, and you ride that for a while until your body gets used to it. And maybe you stay there. Maybe that's your optimal. And that's fantastic. It's all about finding what's right for you. And then maybe you need to listen to that patient, and they need a little bit more. And I have a very unsupported hypothesis on this, but it's just more anecdotal of what I've seen in my practice. And it does not, if you're listening to this and you're a type A driven, crazy individual and you're on 10 micrograms of T3, you're like, that's not me. Okay, I get it. But in general, you're driven, you're active, you're entrepreneurs, you're athletes, you're go-getters, you're people that are thinking all the time. They're in that high pressure career. They tend to need more T3 because their body's using it, and it kind of makes sense. If T3 receptor sites are in every cell of our body, in our brain, on our muscle, everywhere, then if you're using your body all the time, you're using your mind all the time, you're activating your mitochondria all the time, you might need a little bit more. And if you are working with someone that has a cutoff, and I've fired some functional practitioners that I hired into my practice who said, yes, I prescribe T3. I go, okay, well then let's work together, collaborate. And they had this cutoff in their mind. Well, I prescribe T3, but I don't prescribe more than 20 micrograms of T3. I go, well, that's a shame, because what if Susie Q over here needs 50? So you're going to leave her feeling like garbage for the rest of her life because you won't go above a certain threshold? That's no better. Just might as well go back to conventional thinking and just give everybody T4, because you're leaving them hypo anyways. You have to be open-minded enough to find where that individual lands and what they need.
Yeah. Wow. Such a great way to look at it. So I know we wanted to talk about sex hormones, but I like to keep these around 30 minutes, and we're already well over. So I think we should just wrap this up here, and then maybe invite you over to the PEMA podcast, which is our hormone company. I think that would be a really cool interview with our team over there, which would be a lot of fun. So we'll put that on the schedule for later.
Cool.
So then to wrap this up, why don't you tell people where they can find you and a little bit about what you offer, because I think your services are great.
Thank you. Yes, you can go to dramie.com, DRAMIE. And on that site, you'll find a link to book a call. We offer a free call where we just go over, what have you done already? What have you tried? What are your symptoms? What hasn't worked? What has worked? And then we can really look at that and look at your health history and say, okay, you really need help with, no one's ordering your labs properly. No one's prescribing to you. You need hormones as well. So we prescribe to all 50 states. parts of Canada. That's been my mission from the beginning. After I was misdiagnosed 6 different times, I thought, we really need access to good doctors and good prescribers and the full slew of thyroid medication treatment and whatever combination that works for you, as well as bioidentical hormones. So that was my mission from go, to be able to help people in all 50 states. So I built a team. We can prescribe to all 50 states. Yes, we do bioidentical hormones too, because those are just as important. And yeah, it's a lot of fun. So from that site, you'll also find my Fixer supplement line, where we have T2 formula. That's a forgotten thyroid hormone. We didn't even go down that pathway.
Yeah.
That increases metabolism and energy. So you'll find a lot on that site. But if you are interested in working together, it's just book a free call and we'll go over everything with you.
Okay, awesome. Well, thank you so much for your time. Always fun talking to you. You're super easy to interview, so I appreciate your expertise on the thyroid.
Thank you so much, Doug. Thank you.
So I hope you found that interview helpful, and thank you so much for your time and making it to the end of the interview. I found that conversation to be really helpful, even for me, to understand her perspective on how to diagnose from a treatment perspective, all the different things that she's looking at. So I think she has a wealth of knowledge, and I would encourage you to follow her and find out more about her if thyroid is your primary concern. If you are still trying to figure out your bone health, though, consider coming to our masterclass. If you haven't been to our masterclass yet, look for the link in the description. It's totally free. We talk about the common myths and misconceptions and have plenty of time for Q&A at the end. It's really a great opportunity for someone who is trying to figure out what's next in their bone health journey. So if you haven't done that, please do that. And remember this, that a diagnosis of osteoporosis is not the end, but deciding to reverse it is a beginning. I'll see you in the next video.